Right.
My friend. Hi everyone. Hi everyone. Can you hear us? Can someone just give us a wave or a thumbs up if you can hear us?
Oh, great.
Yep.
There.
Great.
Super.
I'm gonna close that little thing. Awesome. Well, great to see you all, and thank you very much for joining our webinar, and a big welcome to our webinar today. I'm Anneke. I'm the clinical specialist here at Swaltech. Other people we have here to support us today online, we've got Eric, who is our patient engagement specialist, Maggie-Lee, who gave a very premature wave.
I was waving at somebody who left. I was waving back quickly.
Yeah, Maggie-Lee, Emma, our CEO, and Ella, our marketing coordinator. Yeah, cool. So yeah, we're Swaltech. We're based here in Christchurch, and our day-to-day is developing technology to support people with dysphagia. So the plan today is that we'll talk for about 30 minutes and then have a chance at the end for some questions. So Maggie-Lee is going to start us off with an outline around strength and skill training. She's going to give some background of skill training and then tie it into how you might carry out a clinical assessment and how that might guide a strength or skill treatment approach. And then I will show you through the clinician portal settings and talk about some things that you might consider as a clinician when setting up a program for clients using BiSSkApp. And then, yeah, we'll finish up with an open floor for questions. So when it comes to questions, if you have a question, can you either please raise your virtual hand or pop your question in the chat, and Ella will monitor the chat as we go as well. Just some general housekeeping and house rules. Can you please keep yourself on mute, just to prevent any sound coming through? And then, yeah, if you have any questions or anything that we don't cover today, you're more than welcome to get in touch with us separately or drop a message in the chat and we can follow up with you as well. Our website also is available, and you can book in a demo through our website if you're interested, or make contact through the website as well. So I'll hand over to Maggie-Lee to start us off.
Very good. I'm going to go off script just a little bit because that tends to be what I do. I really like to talk to people's faces instead of circles. So unless you are naked or you just kind of, if you could let us see your face, I'd love to see people that I talk to. So that would be preferred. You don't have to, but oh, there you all come. Hello. There are people. Very good. All right, thanks for that. So I guess my remit for this one is to sort of lead us into a discussion in a general sense about skill training and where skill training has come from. It's still reasonably in the early days, so many people have heard of skill training, many people have not. So just as a bit of background, when we talk about swallowing, back in the early days, if any of you are as old as I am, you will remember back in the early days, back in the 80s, when we started working in the land of swallowing, we tended to look at patients from the outside and we'd observe behavior, and we would base our assessment on behavior from watching them on the outside. Fortunately, we moved beyond that. There are some neurologists that are still doing that, but we've moved beyond that. And we probably shouldn't have said that out loud. Anyway, and we've moved forward now to the use of instrumental assessments, which are very widely used, although there are places who do not have instrumental assessments. And as we moved into instrumental assessments, we started, instead of observing behavior from the outside, we could actually see there where the food was going. So in the early 80s, we got so focused on the bolus. It was a bit of a game of where's Waldo? Is the bolus in the molecula and the piriform? Is it there too soon? Is it there too late? And all of our assessments focused heavily on bolus flow. Somewhere in the early 90s, somebody had this brainy idea of, hey, let's watch the human that's actually pushing the bolus through. So we shifted our focus then away from the bolus and onto swallowing biomechanics. So we look at things like anterior hyoid movement, we look at basic tongue to posterior pharyngeal wall approximation, pharyngeal shortening, below palatal closure. So we sort of shifted our focus to talking about biomechanical movements. Now, when we look at our management approaches, they sort of followed the same course. In the early days, when we were looking for where's Waldo, all of our management was on compensatory approaches. So we turn the head to direct the bolus down the stronger side. We tuck the chin to close off some of the cavities in the pharynx. So we did a lot of compensation. When we started looking at biomechanics, we looked at the person's swallow and said, oh, look, the hyoid is not going forward. And this is where we made a bit of an over assumption. When we saw limited movement on our x-rays, we came to the conclusion that, look, it must be weak because the hyoid's not going forward. So we developed all sorts of muscle strengthening exercises, effortful swallows, Mendelssohn maneuvers to prolong UES opening, tongue hold swallows, head lift maneuvers, all focused on muscle strengthening. And so for the last couple of decades, we've just been making every single dysphagic patient stronger. And I think that in many patients, that's absolutely appropriate. But I also think in many patients, it's absolutely inappropriate. The problem is we're not very good at distinguishing between who is actually weak and who is something else, but we don't know what it is. And so we're making an assumption of weakness based on biomechanical movements. When you think about all of the patients that you might see in your clinical practice, right? If you think about a patient with Parkinson's disease, is weakness or flaccidity, is that a presenting component of Parkinson's disease? Is that a fundamental feature of Parkinson's? That was a question, actually. Anybody? No, it isn't always. Good answer, Maggie-Lee. No, it's not always. And when we think about Parkinson's disease, we have a lot of characteristics of pathology, but none of them are weakness. They may be weak late in the disease process because they've been hypokinetic for a very long time. But weakness is not a fundamental problem with Parkinson's disease. However, when we treat patients with Parkinson's disease, we do a lot of muscle strengthening. And only recently in the area of voice, although it is with greater strength, but the wording is shifting to talking about speaking with intent or working on the skill of other people hearing. So I think that when we look at all patients with dysphagia, not all of them are going to be weak. And so the big question is, strength training may be appropriate when a patient's weak, but if the patient's not weak, we need to come up with something better, right? So we had developed some technology in my research lab at the university some years ago called BiSSkApp, because we wanted to use that as a tool to explore this construct of skill-based training. So it's essentially working on individual characteristics of swallowing using visual feedback to allow cortical modulation of the swallowing process. So that's the whole construct behind skill training. Patients may be dysphagic, not because they're weak, but because they don't have the right motor plan or motor execution in order to produce a functional physiologic swallow. And so we developed this software called BiSSkApp. Through the university, we did what we needed to do to send that to market, which is not a simple process, but we wound up putting BiSSkApp on the university website. People could buy it. I kind of ignored it because I was getting on with research instead of selling things. But it actually looked like BiSSkApp had legs. We had more people interested in BiSSkApp than we thought we would. That was also about the time of COVID, when we were having to do a whole lot of training in the home rather than patients coming into the hospital. And so that's sort of given rise to BiSSkApp, which she'll be talking about very shortly and going through some of the options. But getting back on my topic, the whole construct of skill training was born out of our recognition that strength training is not what everybody needs. We need to find other solutions. And a question that I hear quite frequently from people is, okay, well, I've got John, my patient. How do I know if I should do strength training or skill training? Which approach should I use? And I think, the real answer to that is don't know. We're still trying to figure it out. We're really, quite honestly, still trying to muddle through deciding how do we differentially diagnose a patient with weakness versus other things. There are some things that I think that you can be aware of, or things that you can look out for. On clinical assessment, to me, one of the biggest markers on clinical exam is if you're giving the patient oral intake, do they look different swallow to swallow to swallow? Now, we know that as patients become dysphagic, variability actually decreases rather than increases. So patients will tend to produce the exact same swallow regardless of the bolus. So if you see a patient who is highly variable, it does send a little red flag up saying, maybe this isn't an issue of weakness, because weakness presents the same all the time, right? If you're weak, you're weak, you're weak. You're not weak and weak. And oh, now I've got all sorts of energy. Oh gosh, now I'm weak again. It's not how weakness works. So look at consistency of behavior or obvious variability. I think a big thing on clinical assessment, look at etiology. And as I said before, patient with Parkinson's disease, weakness doesn't come to mind unless they've been with Parkinson's disease for a long time. And then you may have an override of weakness. But the fundamental problem is not going to be weakness. It's going to be motor execution, as we see in arms, legs, and the rest of the patient with Parkinson's disease. Look at your cranial nerve exam. And I think that I'm a big advocate of doing a very, very good cranial nerve exam. Cranial nerve exams will show you weakness at the peripheral muscle. That's what they're very, very good at. You ask a patient to raise their eyebrows and one goes up and the other one doesn't. Then you've got weakness of the muscle on the side that does not bring the eyebrow up. Same for tongue wag from side to side to side. If it only goes to one side, you've got peripheral muscle weakness associated with that. So if you do a cranial nerve exam, and I know that you've seen this in your practice, you do a cranial nerve exam and they look perfect. Not a thing wrong on cranial nerve exam, but they're still very dysphagic. It's highly unlikely that that patient needs muscle strengthening. They need you to work on the skill or execution of swallowing. So cranial nerve exam is a very good guide toward which approach you should take in your treatment planning. The exception being in our sarcopenic patients who have global diffuse weakness that typically doesn't present with asymmetry like we would see with a neurologically induced weakness. So you might see somebody with sarcopenia, then they're going to be bilaterally weak. Otherwise, we need to be thinking about other things. We think about etiology, Parkinson's disease, not a fundamental problem. If we think about head and neck cancer, are cancer patients weak? Or do they have limited range of motion, perhaps, from either surgical intervention or radiotherapy, and they have tissue changes? And I guess my view is in a patient with head and neck cancer, if they're undergoing radiotherapy, I'm not sure I want to do maximum strengthening. They need to keep tissue flexible and moving, but not maximally strengthened because that tissue is irritated. So I think look at your background and what does that background suggest you might see in the patient. On video fluoroscopy or endoscopy, whatever tool you tend to do, look at, again, consistency in behavior. I think you probably have all seen patients that you give them a 10 ml bolus of something, they look great. You give them another one, they look great. You give them a third one and everything goes to hell in a handbasket. And you're like, where did that come from? Because again, weakness is persistent. It may decline over time, but you're not weak and then not weak. And then you're weak and then you're not weak. It doesn't work that way. And that's a good hint to you if you need to go down the strengthening pathway, or if this is one of those patients that we may not be able to say they have spastic dysphagia or swallowing apraxia or ataxia of swallowing. What is ataxia of swallowing? I don't think anybody knows. So our differential diagnosis is not that specific yet. We're still working on that. But I think we can at least say we've got weakness over here and we've got poorly skilled, for the lack of a better term, over here. So they're weak or they're not. What's in this basket, we've got a lot of work to do a better job of defining what goes in that basket. But until we come up with better differential, then I think the safest approach for them is to work on skill-based training, working on motor control, motor task performance, rather than strengthening. Any questions, comments, complaints, curiosities? I love a good curiosity. Take it away, Anneke.
So I'm going to step you through now the BiSSkApp clinician portal. So I'm just going to share my screen. Oops. Oh. Eric, could you just give me a thumbs up if you can see the screen? Thank you. Sorry, you're the one on my screen, so I can see only you at the moment. Cool. So yeah, I'm going to run you through some of the settings that we have in the BiSSkApp portal, in the clinician portal, and some of the options that we have and some considerations that clinicians may want to make when setting up a program for a client. So as Maggie-Lee said, there's two areas that BiSSkApp can support. So we've got skill training, which focuses on the coordination, timing, the precision, and the skill of muscle movements, and strength training, which is focusing on building muscle force through effortful type swallows. So within the portal, both options come with default settings. But that's not to say that these settings that are the default are the ones that you should use. And it's definitely not a set and forget or an off-the-shelf type system. Building on what Maggie-Lee said, it's really important that as a clinician, your clinical reasoning comes in here to do that identification or that thinking around whether it might be a strength issue or a skill issue or a both issue based on your clinical assessment of the client. So before setting up a program, that's kind of the number one question, or the first question you might be asking yourself: what is the underlying cause of the dysphagia? Is it a strength issue? Is it a skill issue? And then would BiSSkApp actually be a good tool to target those strength or skill deficits? So obviously, if weakness is the main issue, then strength training makes sense. But like Maggie-Lee said, if there's no reason to suggest that weakness is present, which you may have seen through your cranial nerve exam or your observations of the client, then you might be thinking more about those skilled elements, the timing, the coordination, and skill training may be a better option in that situation. So the decision should always come back to what you as the clinician know about your client or your patient and what you've observed in a clinical assessment, and what you know about their underlying medical condition as well. So the way that BiSSkApp training is structured is a little bit like exercises in the gym. So we have our swallows, which are our reps, our blocks, which are like sets, and then our sessions, which are workouts, like a workout. So swallows are grouped into blocks, blocks make up a session, and then the sessions are spread throughout the day. A really common question we often get is how many swallows should patients be aiming for, or what's the ideal dosage? And for this, we just don't have an answer because there's no data around it as such, and we don't know your patients. So we can draw on some evidence from our motor learning principles and neuroplasticity principles around this. So thinking about the intensity and increase in repetitions being more likely to see an increased effect. But there's no exact number of repetitions that we can confidently say is ideal, and it depends so much on the patient and what they can tolerate, and other things like that. We do have some early evidence from the Parkinson's population that shows around 100 to 120 swallows per day split into sessions. So for example, 50 in the morning, 50 in the afternoon, saw some positive outcomes. So this number could be used as a starting point, but it's also about keeping in mind what's manageable for the patient, and their routine and their energy levels, and how you structure the program around that. So if we have a look here at the portal and how a program gets set up, the initial program settings here are where we start to control the overall schedule and the overall intensity of the program. So here we can set the days of the week. So this is what days the training will happen. So you could select it for 7 days a week, or it may be that some people want weekends off, or it may be appropriate to do every second day. The sessions per day is how you set how many sessions are to be carried out within the day. So for example, it might be one session in the morning and once at night. Some patients may be able to better cope with shorter sessions but more frequently. So you may be looking at short but often, or short but frequent sessions, broken down across the day. The minimum rest between sessions. So this is like almost like a lockout period for the patient. So it means that they can't just jump in and complete their scheduled sessions back to back. So it helps distribute the training across the day. So yeah, kind of going with that principle of the sessions being intensive blocks spread out across time rather than completing them all at the same time. Blocks per session. So the blocks per session works in that each session is divided into blocks like sets in an exercise. So here we can break down the sessions into manageable blocks as the client needs. And then our swallow length is the duration of a single swallow sweep. So typically we set this for around 30 seconds, and that allows the client enough time to swallow once in that 30-second sweep and then rest. So you can imagine that if you're swallowing a number of times across a short period, it can get really hard to keep swallowing and keep producing swallows. So we really aim for just one swallow within that 30-second block, and then use the rest of the time to rest, gather the secretions, and be ready to swallow again in the next sweep. So this time here can be extended, and that can be useful for patients who may have particularly dry mouths or limited secretions, or just for those who need a little bit more time. I guess the flip side of this is that if it's too long, you can risk losing attention. So it's a good one to gauge with your clients and trial out with them as well. The next section here is the skill to strength ratio. So this is how we identify if we want the training to be strength or skill or both. So it's just a matter of toggling the strength and the skill to get it to the desired sessions that you want for your patient. So if you are targeting both strength and skill, we do recommend separating them out into different sessions. So by that, I mean doing strength in the morning and skill in the afternoon, or something like that. And the reason for that is to avoid any interference. So if we think about that principle of interference, what it means is that if we're targeting, say, skill training, for example, when we're doing that skill training, we're working on getting that neural pathway really strong and really well oiled and well greased. So we really want to be repeating that and focusing on that one task to strengthen that neural pathway. If we were to bring in another task, say strength, that's a different neural pathway that we're using. So that just risks that those two different neural pathways kind of interfering with the skill learning task, or with the task that you're trying to target. So if you're targeting strength and skill, make sure that those sessions are separated out. The next bit here, we have settings specifically for our strength program and our skill program. So these settings allow us to fine-tune what really happens within the sessions themselves. So the swallows per block, that lets us select how many reps or how many swallows go into each block. So again, this is where you'd be thinking about what is the kind of overall target number of swallows that you might want to be achieving in the day, and how you break that up into your blocks and your sessions. The rest between blocks, so this is like an enforced break between the blocks, and a bit of a break in between the training. So it can be used as an opportunity for the clients to take a rest, have a break, have a quick glass of water, and then it's also can be a really good time to think about kind of transferring what the client's been doing in their swallowing training to a real world task as well. So if they're having a glass of water or a quick bite to eat, getting them to really think about their swallowing and think about what they were just doing and how that transfers into their eating or drinking. The hit miss sensitivity. So this is how the client's performance adjusts the difficulty. And essentially what it is, it changes how often the target needs to be hit or missed before it gets harder or easier. So the idea being, if a client consistently hits the target, then the target gets harder. If they miss it, it eases off. So with the skill training, the box will get larger if a certain number of targets is missed, making it easier to achieve. And it will get smaller if the target is hit, making it more difficult to achieve. And the same thing with the strength task, except the line moves up or down to make it harder or easier. And then the target change percentage, this is how big the change in the target is when the difficulty shifts. So this is a good way to adapt if you want to make it really obvious or more subtle around how the target shifts. And it's another way to provide that real-time in-session feedback to get that visual picture of the target moving. And then finally, down the bottom, we've got graph settings, and these modify the range of the target placement. So when a client starts with BiSSkApp, they go through a calibration process, which individually selects where their target placements will be, reflective of their own normal swallows. But these graph settings just allow for fine tuning of that and modification of that if needed, based on what the client's doing and how they're performing. So that's the settings. I just thought I'd share a quick a few things that we've learned along the way when we've been working with patients and when we've been supporting clinicians to get started with patients as well. And a really big thing is that we've learned is that you might have your target number of swallows that you want to be achieving in the day, but a really good tip is to start small and just get going. So say start with 20 swallows in the morning and 20 swallows at night and build up from there. So we really want patients to be able to have that have success quickly and have a sense of achievement and feel like it's manageable and have them kind of wanting more and feeling like they're building, rather than starting with something that feels really, really intense and feels like it's too much and then having to kind of backpedal from there. So would very much suggest starting small and then checking in, and if it's going well, building up from there. As a clinician as well, I'd say definitely expect to provide a little bit more hands-on support in that first week, and especially if clients or patients are less confident with technology. So what we've found has been really beneficial is if you get a client set up with BiSSkApp, making sure that the next day you're able to kind of check in with them and problem solve with them on the spot, so that you can kind of keep the momentum going and have that sense of success, rather than just leaving them to it and then having some barriers right at the front that can then turn quite hard, that can then become quite hard to overcome. And then, if you're able to kind of spend that or invest that time upfront initially, it kind of increases the success of clients being able to complete their training independently, and then you can start to kind of move away and have that more remote monitoring and adjust their settings remotely and monitor remotely through the clinician portal, rather than needing to have that hands-on support all the time. So that was me. So we can open the floor now for any questions, if you want to pop them in the chat, or feel free to raise your hand or take yourself off mute and ask away.
I just want to cut in there and add that Eric is here to add that patient or peer support perspective. I know there are a few clients or patients with dysphagia in the chat, so if you've got any questions about how it is to use BiSSkApp from that patient perspective, we can pass over to Eric there too.
Some of the chat.
There's a few in the chat that are waiting here. This one's from Maggie-Lee from Jody. Is it appropriate to undertake a program like McNeil Dysphagia Training Program / EMST at the same time? I assume that's at the same time as BiSSkApp.
Yeah, I think that we would never, I mean, what you do with your patient is based on your clinical judgment of that patient. I guess the only red flag that comes up in regards to that is that I think, again, when we talk about principles of motor learning and really wanting to facilitate cortical reorganization and cortical modulation, that if you stick with one task, you're more likely to accomplish that goal. So I guess my first thought for me and what patients I may see is I would probably choose to say, let's do this for a block and then do this for a block and then move on, rather than trying to have multiple layers where they're doing lots of different things. But I also really want to emphasize that BiSSkApp is not a treatment. BiSSkApp is a tool. And you are the clinicians that are using your very good clinical judgment, because you know your patient. We don't know your patients. We know a lot of patients, but not your patients. And so what treatment plan you put into place may utilize BiSSkApp, and it may be BiSSkApp forward. It may be the primary approach or tool that you use for rehab. But how you mix that with the other things depends on your clinical knowledge and your knowledge of that patient, if that makes sense.
Another one from Emma. Have you ever used BiSSkApp with a bolus, or do you tend to use it with saliva swallows?
That's always, do you want that or you want me to do that?
I can try.
Go for it. Go for it.
So BiSSkApp is designed to be used with a dry swallow, so swallowing your secretions. And the reason being is that on both skill and strength training, the way that the targets are set out is that the strength target is set at, like, for an effortful type swallow, so it's set at 2 times the person's normal swallow, and then the skill targets are set within 30 and 70% of that person's relative effort for their normal swallow. And then the targets also move in timing along the screen as well. So the danger is with doing BiSSkApp with a bolus is that the requirements to take the bolus may be different to the requirements that are on the screen. So for example, if it was an effortful swallow on this target on the screen, and the bolus that was in your mouth actually didn't really require an effortful swallow, then it's not really reflective of what you are doing with the bolus versus what the target is doing. So it doesn't line up.
I think the only thing to add to that is, particularly for the skill training component, you're trying to get them to think about swallowing and think about what the muscles feel like when they're swallowing at a certain time and amplitude. Adding in the third factor of the bolus in real time kind of complicates that picture. And of course, we've struggled with this a lot in my research lab. Oh, do we use a bolus? Do we not? Do we use a bolus? Do we not? We've had lots of discussions about this, because obviously translation is really important. We want this to transfer to oral intake. And that's where Anneke made the point between blocks of training. You focus on what your muscles are doing. And now I've got 2 minutes or 3 minutes, and now I'm going to have the patient take some sips of water, really concentrating on what does the water feel like, how do we need that to go down. And they've got a period in the middle to transfer what they've been doing in training to oral intake. We know from research in Parkinson's disease for this project, where although BiSSkApp skill training using BiSSkApp was done with dry swallows, it transfers to improve function for bolus swallows, for both liquids and solids. So I think that there is every reason to believe that if you train with dry, you're going to see effects on oral intake. I certainly have seen that in practice.
Got a big one from Akshan. In PD, this is a bit of a comment as well, but it's really interesting. In PD, when many patients struggle to control saliva, one method we've used forever is increasing swallowing ability via swallowing saliva and repeating this, essentially focusing on skill early on. Patients at this stage often don't present with dysphagia that affects fluid or food overtly. However, the impact is huge for many patients and impacting on. Essentially, we're using cortical control to override reflexive control. I've seen a lot of improvement in swallow timing and range, nothing measured as yet. This is basic skill training, but without the visual feedback. It's great to have the visual feedback. It works using SPL measures and PD. Any comments or thoughts from the BiSSkApp team for people living with idiopathic PD?
You know, I love your comments, and I think those are all very relevant to this. I think with PD, there are patients that you get very early on that aren't having trouble with swallowing per se, but one can expect with PD that ultimately they will. And I think it's a great thing to start training very, very early, even when it just may be a secretion management issue, because you're just trying to increase that wiring. And you know that. You're trying to increase that wiring and increase the cortical substrates for swallowing. I think that this is where I just have to throw this comment in, and I'm wondering if I can find this quote quickly enough. I probably can. But way back over 50 years ago, way back a long time ago, there was a fellow named Chuck Larson in the US. And he made the comment 50 years ago. This was back before Andre Jean's work on a brainstem organization for swallowing. It was way back when we thought swallowing was a pure reflex. And he made the comment that patients need to be taught to swallow using their cortex and to use cortical control of swallowing. He said it much more eloquently than I did, because I can't find it quickly on my computer, but he said that 50 years ago. And what have we been doing for the last 50 years? We've been trying to make everybody stronger. So I think it's now about time we listen to Chuck Larson and we start looking beyond strengthening, and strengthening is very appropriate, but I don't believe it's appropriate in Parkinson's disease. And I think, as you've said, that I think we really need to look at teaching cortical control. A really good way to do that is to have technology that lets you see what you're doing when you swallow. I'm not sure if that answered your question or if I just got distracted by my own agenda, but there we go.
Because we don't have any other questions currently, keep them coming if you've got them. No question's a bad question.
Sean's got their hand up. They might want to reply to Maggie-Lee.
Yeah.
Oh, sorry. I'm just I've unmuted myself, and I'm just thank you so much. That's really reassured me. Actually, I'm not going to put my camera on because it's 5:45 in the UK, and that's where I've joined the call from, because I was just so excited about this, and it actually really does. My comment about the sound pressure level meter is with, when I've seen clients using LS, the Lee Silverman technique, and we use the SPL, as you all know, where you've got the numbers. And I think all the speechies on the call probably know that when you've got a client who's seeing their decibel reading going up, they get really competitive. And I love seeing that. And I think having that visual feedback is the missing link, really. It's the bit that actually gets people understanding what this swallow that we've taken for granted all of our adult lives does. Yeah. And then suddenly they have to know how to use it. So I think having that visual feedback is just amazing. So thank you for answering my and I'm very passionate about Parkinson's. So, I kind of think we can do so much more so early on. And something I have, like you said, having this tool would just be amazing, because I think it empowers people in their homes as well. And I'll stop talking, but I just wanted to add to that without you seeing me in my starry pajamas.
That's great. And thanks for that comment. I guess one thing to add back to you for that is that one of the things that we find, especially, in Parkinson's disease in a lot of respects, because many of them are able to use cortical control or more conscious control, because cognitively they're very good. But when you think about it, you grow up learning to run and you grow up learning to use your hands, and there are things that you can see and things you can control. And I can remember when I was quite a bit younger than I am now, and I went to a gym and they said, oh, yes, think about do you feel your core muscles? And I'm like, I don't know what my core muscles actually are. That I think we don't have good insight into what our muscles are doing until we really focus on them. And if we think about swallowing, hey, they don't have any idea how they're swallowing. Most of us don't. And so when you're trying to explain to them, you can very well say, oh, yes, and your anterior belly digastric, you need to work on that one, because that's Greek. So I think the more information we can give them that helps them understand what are those muscles doing right now, and you get that answer from looking at feedback, and then you can manipulate it. I guess one more comment on that, sorry, and then I'm going to shut up. Once you get me started, I tend to like go on and on too far. But the one other comment to that, I don't know if you've seen the videos of patients with Parkinson's disease and gait. And if you ask them to walk across the room and you see their feet, these little shuffling steps when they're off meds and not doing well, little shuffling steps and difficulty turning corners. And when I see that, I just think of a tongue. That's what they do orally when they're not well controlled, is they can't really move a lot to manage the bolus and have difficulty transitioning it into the pharynx. But then if you put lines down on the carpet in front of them, there they go. All you had to do is give them lines on the carpet and they step over the lines with no trouble at all. And I think that is such a powerful example of the role of visual feedback in modulating neural control. Okay, I'll stop now. Next question.
From Emma, if you've determined an underlying weakness or skill in a patient's swallow, is there anything that would make you think BiSSkApp is not appropriate?
The only thing that I would think BiSSkApp was not appropriate, well, no, because BiSSkApp, again, is not treatment. It's a tool. So I guess then the question is there anything inappropriate or contradictory about strength training or skill training? And there are indications, subtle indications, I would say, in the literature that muscle strengthening or strength training can be contraindicated in some patients, that it can cause more problems than it can fix. And so that literature is there. It's taken a long time for that to be explored, but there is some hint toward that. So I'm always a little bit cautious about wanting to do strength training unless I really look carefully at the biomechanical movement patterns. Skill training, we know of nothing yet. And I'm saying yet because I don't know what's in the future, but it's very hard for me to imagine that there would be any adverse effects of monitoring your swallowing with visual feedback and adjusting accordingly. I can't envision that, but it doesn't mean it's not there. So I guess my general belief, if I have a patient and I can't decide, do I do muscle strengthening because they're kind of looking weak, or they do have characteristics of weakness, but they also have characteristics of poor skill, motor planning, motor output. My first response is going to be, let's do skill training first and see if that fixes the other problem. So if you get them swallowing with a more normal pattern, then that might take care of the appearance of weakness. You also, just by repeating swallowing over and over again, not at maximal amplitude, just through task repetition, you will get some strength effect. So I would tend to default to skill training before I went to strength training. If I was sitting on the fence, I can't decide which to do, I'd go that direction first. And then I may find later that didn't sort it. So now I need to do strength training.
Got one from Chloe. With a 30-second swallow time for those with xerostomia, I think that's how you say it, can they have sips of water during this time to rest, or do they have to wait until after the 30 seconds to take a sip?
No, absolutely. Yeah. So if people need to have a drink, they need to have a drink. So in the patient app, you can pause the training in that 30-second sweep. So if you needed to in that period to have a drink, you can absolutely do that. Yeah, we just say don't have a drink of water while you're swallowing to hit to try and get the target. Either do your swallow, then pause and have a drink, or have a drink, pause, have a drink, press start, and then do your dry swallow. Yeah.
Question from Eleanor. In patients with head and neck lymphedema, I think, do the swelling and tissue changes affect sensor readings, and are there any recommended adjustments to ensure accurate measurements?
The accuracy of the measurement, I'm not going to say it's not important because it's EMG, it's a measurement. You want it to be accurate. But if a patient's amplitude is smaller because they've got lymphedema, then it will always be smaller because they have lymphedema. You'll still be able to see what it is that you need to work on. So as long as you can see a waveform and see a peak that's associated with swallowing, then that's fine, and it's not an issue. Where it becomes a problem is if you have patients who have a lot of, and this sort of leads off of Anneke's response before, if you have a patient who has a lot of movement at rest, or if you have a xerostomach patient that's doing a lot of things in that 30-second period, they're talking a lot or drinking a lot or doing this a lot, then it makes it very hard for them to focus on swallowing. So the most primitive form of motor control is not moving when you don't want to move. That is motor control. So if you put the sensor on a patient and you've got all of this stuff at the bottom of the screen, and they're talking and they're looking at you and they're fiddling around and they're wiggling, and you've got all this noise on the screen, you need to tell them, stop that. Just stop that. Watch the line. Sorry. So sorry for the last. Anyway, make the line flat on the screen. You need a nice quiet line to show us that you can control the muscles. You need to be in charge of your muscles. Control that movement so you're not moving, then swallow. Control, swallow. Control, swallow. So you don't want a lot of movement. You don't want them talking to you. As you can probably guess, the hardest thing for me when I'm with a patient in treatment is I just like to talk far too much. I like to talk way too much. But really, you need to be quiet so that they'll be quiet, so that they'll focus on swallowing. And that's been a very hard lesson for me to zip it, Maggie-Lee, so the patient can do their work.
Got one from Sonia. I'm sorry if I'm pronouncing anyone's names wrong. This question is, are there any changes to be done with post-medication? Are there optimal times versus non-optimal times?
I'm presuming you mean Parkinson's. Don't know that, but I'm going to kind of make that presumption that I think that if you certainly, it's best to do training when you've got the patient optimally functioning so that they can really concentrate on what they're doing and they have control of the muscles. So if you have a patient whose swallowing appears to be influenced by medication schedule, then I would do training when they're in an on period of medication, when they've got good benefit from their drug therapy. That's when I'd schedule treatment. A lot of patients, drug therapy doesn't have a strong effect on swallowing in Parkinson's. And if that were the case, I would just do training at the same cycle. Doesn't necessarily have to be when they're on, if it doesn't really influence swallowing, but in the same time of day after day, if that answers your question.
Right, I've got 5 minutes left and just a couple more questions here. One from Josh. In patients with motor neuron disease, would skill training be contraindicated as with strength training in EPG?
So I'm going to answer a question with a question. Is strength training contraindicated in MND? Always. I don't know that it is. I think Emily Clowen did some really nice work several years ago, did a systematic review or two looking at strength training and motor neuron disease, and found that although we've always had this assumption that it was contraindicated, we need to spare the muscles so they can use them functionally, yada, yada, yada. There is not really evidence that that's true in a general sense and specific to speech swallowing corticobulbar stuff. So I guess my view would be that, and we did some research several years ago using BiSSkApp skill training in patients with motor neuron disease. It was a PhD thesis by Paige Thomas. I'm still waiting for her to get her manuscript finished. So if any of you know her, drop her an email and tell her to get the work and get her manuscript done. But anyway, we did a study of motor neuron disease. It was very hard to get a big enough sample size to be able to come to any strong conclusions. We saw 1 or 2 patients. We saw some subtle improvements, but they were not big enough to say, yes, this is a treatment for motor neuron disease. However, patients didn't get worse. And I think when you look at those degenerative patients, you need to ask them, and this is a clinical thing, it's not a BiSSkApp thing. You've got motor neuron disease, which is a hideous disease. Do you want to spend time doing treatment to perhaps, on the off chance, maybe maintain function a little bit longer? We don't have data that proves that, but we also don't know that it's not true. Or do you just want to get out and enjoy your life? And I think different patients have different views. Some diagnosed, they want to do treatment because they want every possible chance of prolonging life, and good on them. And then there are others that are like, heck no, I want to go on a cruise to the Bahamas, and then I want to spend Christmas with my family. And I don't want to be sitting around doing treatment that's not going to help me. And so it's up, in my view, it's up to the patient. But I would rather do skill training to increase cortical circuitry than strength training, in my opinion. Long answer, sorry.
Great answer.
Carry on.
Final one we've got for today is for Eric. I wonder, Eric, if you tell us a little bit about your story, your background, your experience with biofeedback. And our challenge has asked specifically, what are your thoughts on the app and the challenges?
Yeah, sure. Great question. I guess the main challenges for me or any patient is their physical makeup, like being able to work the actual sensor and the adhesive patch and all that. But I think once you find out how your body works, and this, like for me, I had a stroke. So once I worked out how, my new body worked out, it was quite easy because you could just figure it out, and like Maggie-Lee said, with the motivation going to the Bahamas or sitting down doing training, for me, it was being able to eat fried chicken from KFC, and I guess that motivation really helped me push through the challenges. And what was the second? Oh, what I thought about the app was really cool because I'm biased and I'm involved in a lot of the user interface. What I like about it is that it's really simple for anyone to use, and we're still making changes as we go, and it's never really it's constantly evolving, I guess. And yeah, thanks.
Great, Eric.
Great. That takes us to 5 o'clock.
That's it. Oh, well, yeah, thank you everyone so much. Nice to see some familiar faces. Eleanor, Lahini and Bryony. I'm just scrolling through to see who else is in. Oh, Nathan. Oh, it's Nathan.
Maggie, our pal Lillian is there.
Huh?
Oh, Jenny.
Our pal Lillian from Adelaide came hung out in the booth. I think she's had her baby.
Where is she?
Oh, Jody.
Congratulations, Lillian. Is that
Yeah.
Thank you very much. Here I am with Bubba. It's good to see you all.
Lovely.
Yeah, but thanks everyone so much for joining and participating. If we didn't get to your question specifically, or if you have something else you want to know, please do feel free to get in touch. We'd love to hear from you, and yeah, love to chat more. So.
We love to talk.
No, do not.
So yeah, have a great rest of the day, and hopefully we'll chat soon.
Bye. Bye.
Thank you.